So, pruritus or itching is one of the common symptoms that people have with dermatological conditions, and their pruritus might be what they end up actually going in to be evaluated. We also know that it can be one of the first indicators of a systemic problem or systemic disease. In particular, we see pruritus with chronic kidney disease, diabetes mellitus, lymphoma, some of the obstructive jaundice or biliary disorders. So something that we would definitely pay attention to and find out kind of what the underlying cause might be. We know that pruritus is more common at night, and partly they think because there's less it's not distraction. So you lay down and all you do is feel the itching and then have the tendency to scratch. As far as the physiology, there ends up being kind of a vicious cycle because we itch, and then that itching or scratching basically once we itch, we're going to scratch, and that scratch basically causes histamine to be produced, and then there's more pruritus when that histamine is released. So we have to find a way to kind of stop that itch-scratch cycle from happening. And certainly we're concerned about itching or scratching so hard that we break skin open, so we need to be careful about that with patients too. Treatment of pruritus will definitely depend on the cause, and we want to do a thorough assessment to find out where they started on any new medications. Do they have environmental allergies, hay fever? Do they have a different makeup or soap or lotion product that they're using? Again, a main goal would be to maintain the skin integrity. Even if we do have itching, we don't want to break open areas of skin. And so skin integrity and kind of relieving discomfort are basically kind of our two priorities. There also might be body image issues, especially like let's say if you have big patches of psoriasis that you're concerned about how they look, plus you have the itch that goes along with it. As far as medications, topical steroids, corticosteroids can be prescribed, or anti-inflammatories to decrease the itching. We do know, and I'm sure some of you have used that with yourself or with children, the topical hydrocortisone cream that is available for different types of itching skin issues. Oral antihistamines such as diphenhydramine, which is your Benadryl. Diphenhydramine is over the counter, or hydroxyzine, which is your Atarax or your Vistaril. So these are medications that, well, the diphenhydramine you can get over the counter. Otherwise, you will see them commonly prescribed, and they can be prescribed for other things besides itching. They both can be prescribed for sleep, and hydroxyzine is a muscle relaxer, so there can be multiple actions or effects of these medications as well. As far as education, we want to make sure they understand that heat, that excessive heat as far as showering or bathing is going to cause further pruritus or itching, further vasodilation and release of that histamine. So they shouldn't have hot temperatures. More of a tepid, lukewarm type water would be ideal. Decrease activities which cause perspiration, or if you are sweating a lot, to make sure that you do shower afterwards if you're working out or something. Avoid scratching, of course, using your nails and actually scratching and opening up areas. Bath oils can be helpful to add some moisture, but obviously make sure about the fall risk whenever we're using oils. Cool compresses, and again, a wet cool like washcloth or rag can be very helpful. Doesn't necessarily have to be an ice pack, but definitely something cool. And ice certainly can help too. That will kind of constrict the vessels and help with the itching. A bedtime routine as far as some sort of a transition, especially because we know itching can happen more at night. And then just a review of the pediatric considerations. We did talk about infants with their nails need to be cut short, or for infants that you can keep their little short sleeves. You can keep their hands covered underneath their sleeves, or they can wear little mitts. So atopic dermatitis or eczema in children or infants, we definitely have to help them, because then we're not going to be able to tell them to not scratch and have them know what we're talking about. So acne is the next disorder or the first disorder that we're going to talk about, and this is the most common follicular disease. It's most common, of course, amongst adolescents and young adults, kind of in that 12 to 25-year of range, equal by gender, although we do know that it peaks earlier in girls due to onset of earlier puberty. There's going to be excess or more androgens that are stimulated, that male sex hormone during that time, and also the sebaceous glands are going to be producing or secreting more oil. If you think back to the picture where we had the epidermis and the dermis and the hair shafts and hair follicles go into the dermis, basically they can get plugged, and then basically all of that flows out onto the skin off the top of the hair follicle shaft. And then we can get all of those areas that are plugged up, and all of that stays underneath the skin. So it can be genetic. There is more of a genetic predisposition and family history of acne, but also, of course, hormonal. Now, there can be kind of a second period of time, usually in kind of middle, well, not even middle, like 30s, in the 30s for women after have had babies. And again, there's kind of like a second like hormonal surge or change after you've had children. And so sometimes people that didn't have acne at all as a child, or as a, I should say, adolescent, can have more of like an adult onset acne. And that's typically for sure hormonal at that time. So you can see the technical terminologies for whiteheads and blackheads. Basically, the open comedones are the blackheads, and that should make sense because if they are open, that means that anything from the outside can basically get on and cover up that, and then plug up the follicle and the shaft, and then it shows that dark color because of the dirt and stuff that's over the top of it. And we know that if they are deeper, that we can get more cystic type acne, and definite scarring can happen. So if they're having real significant cystic clinical acne, it's not any wash and good skincare in the world isn't going to help that. So they're probably going to definitely need some medication. So here's the picture just really showing that hair follicle and the sebaceous glands that basically secrete more oil. And you can just kind of see how all of that gets infected and inflamed, and it comes out on the top of the skin in the form of a pimple. But all of it below the surface is what needs to heal. So even if you use some spot treatment, let's say, and you get that kind of outward pimple to heal, we're not really fixing that deeper internal problem. So persons with clinical acne have much more than just on the surface that they need to treat. So there are several different things that we can do for acne. The goals are definitely going to be decrease the bacterial colonization and decrease the amount of sebaceous gland activity or production of oil. And then really ideally we need to keep those follicles all cleaned out and prevent them from getting plugged. And then overall we'll be decreasing that chronic inflammatory response that's happening. So reduce the bacteria, reduce the oil, reduce the inflammation, and then try to keep those follicles open. So if you were doctoring or taking a young person to dermatology, let's say for treatment, they're going to start by just saying, are you washing your face twice a day? And there's over-the-counter benzoyl peroxide or salicylic acid and tretinoin. Those are the over-the-counter ingredients that if you were looking at your acne washes and lotions and spot treatments, those are the ingredients that you're going to see. Those are going to decrease inflammation. They're also going to help to remove the follicle plugs and decrease the amount of oil production. So washing face twice a day with just those over-the-counter products is going to be very, very helpful, and using some of the spot treatment as well. They'll talk about oil-free cosmetics, and certainly we have a lot of this age group that are athletes, and are they waiting several hours to shower and wash their face after they've sweated and things like that. So that kind of is very important initially before they would ever try any other types of medication or prescription medication anyway. So oil-free cosmetics, making sure you're taking good care of your face and your skin. And it's not just your face. I mean, people get acne on their chests, their backs, their shoulders. And those are kind of the main areas that they're definitely assessing for. Diet, there's not a lot of documented research on this. However, people probably know if they have things that trigger. So for some people, chocolate or caffeine or cola or fried foods, things like that sometimes can trigger more of a hormonal fluctuation and can impact a little bit. Now, if we're not having good luck and good results with just the washing and the spot treatments, and the tretinoin is a a lotion that you put on at night every night, well then they would definitely go towards more of the antibiotics. So there's topical clindamycin, and they might even start that right away with just the face wash over the counter. This is just a topical spot treatment that you just put on your blemishes a couple times a day. And then if they're actually needing to be on oral antibiotics, it'll be on a tetracycline type of antibiotic. So doxycycline or minocycline, those are all in the classification of a tetracycline antibiotic, and those are going to be the ones prescribed for acne. And this isn't just like a 7 to 10 day like we're used to antibiotics with other things. This is actually being on an antibiotic for 3 to 6 months. The big thing with tetracycline type antibiotics is to remember that they cannot take that with milk. That will decrease the absorption. So if they're on minocycline for acne, then they should be educated about not having like yogurt or even like their cereal with milk in the morning, if you think of what most teens are going to be eating. Or I know the doctor will say, take your medicine first thing when you get up. By the time you shower, get ready, whatever, it's fine to have a bowl of cereal before you go to school. So either way, it's something that we talk to them about. And then if they are resistant to and not getting the effectiveness with antibiotic and the over-the-counter face washes, the other medication that they can prescribe is isotretinoin, which is Accutane. Accutane, there's several things that it's like a 6-month time period, 6 to 8 months that they would be on it. For women or for girls, they have to have a pregnancy test each month because it's can form defects in the fetus, and then they have to document 2 forms of birth control. So they have to be on birth control plus like condoms, and they have to do like an every month verification of all those things in addition to their blood test in order to be able to get their next month prescription. They do monitor liver function tests and cholesterol as well. So for the guys that are on Accutane, they obviously don't have to have a pregnancy test each month, but they still have to have those other things in place as well. And the Accutane is very, very effective. The main side effect is it dries you up really bad. So it basically is drying up all of that oil and making sure that those follicles don't get plugged again, and so that it's treating that acne long term. So typically most people, and it's that clinical cystic acne too that is really resistant to the other, once they get cleared of that, they typically will not have acne again. I mean, not that they wouldn't ever have a single pimple again in their life, but it would just be very minimal if they have any little breakout at all. The next condition is eczema or atopic dermatitis. This is a chronic condition that has remissions and exacerbations. It is an inflammatory response. You maybe learned about it in immune. It's a type 1 hypersensitivity where there is an increase in IgE and eosinophils. So there isn't really a known etiology or cause, but they do believe family history is common. Eczema is common or highest, I guess, incidence in infants and children. About 10 to 20% of infants and children are affected by eczema. And then the common sites, the face, the neck, the upper chest, but especially you'll see little infants in young, 1-year-old type age where they have them like on their cheeks and their neck and kind of on their arms and things like that. So as far as eczema, it's, again, we want to reduce that inflammation. We want to prevent secondary infections, especially if they scratch and open up their skin. How eczema will look is that very red, so erythema, but it's dry and scaly and very, very itchy. And that's the problem because you have this younger age group that is just instinctively going to itch and scratch. So may have breaks in the skin and bleeding and oozing as a result of the pruritus and the scratching. And here's a picture where you can see those patches of eczema. A lot of over-the-counter naturalistic type products too out there now that can be very helpful. And sometimes the eczema can be associated with food allergies in this age group, so they might be doing some of that allergen testing at the same time. So eczema management is very similar to like pruritus almost because, it's basically avoiding any chemicals that you might be having a reaction to, no harsh soaps, we don't want to have frequent bathing, we want no hot water. And when we say avoid frequent bathing, I mean, this is not bathing daily, this isn't even maybe bathing every other day. So for infants with eczema, they maybe say like 2 to 3 baths a week. And so a lot of parents are used to giving their little babies baths every day and it helps soothe to them and things like that. But if they have eczema, that's really bad for them to have that frequency of being in the water. Again, remove any allergens, whether it's environmental, animals, dust, things like that. There will be use of emollients. Again, this is very more of a dry condition, so more of the emollients and creams for that sort of condition to reduce the inflammatory process. Antihistamine type medications for itching. They may be on steroid therapy, topical or oral, to again suppress the immune response. Otherwise, soft cotton fabrics. So again, we need things not to be scratchy. We can't have fabrics that are itchy themselves because that's just gonna, make it worse. Mild laundry detergents, or you'll have, a lot of the newer washing machines will have like a double rinse cycle, and so they would be double rinsing, and then just using just a very mild detergent like Dreft. Avoid animals, dust, sprays, perfumes, any of that kind of stuff. Again, especially if they don't know the cause of the eczema, they want to try to remove all of that. And then again, making sure that the nails are short, that they're wearing gloves when sleeping, or have little mitts on their hands, or for infants, have their little sleeves over the top of their hands so that they can't actually scratch open area of skin. Psoriasis is another chronic, non-infectious inflammatory condition where we don't really know the etiology, but there does seem to be a familial or genetic predisposition. What's happening with psoriasis is those epidermal cells on that outermost layer of our skin are producing 6 times faster than the normal rate. So it's like an autoimmune, like an overreactive immune system that's reproducing these cells too fast. And then these cells basically build up. You have a buildup of the living plus the dead skin as a result of that increase in skin cell rate growth and turnover. So then we get these dry scaly patches or plaques of skin. So dry scaly rash, they kind of are silvery scales or plaques. You'll see them typically on the scalp, in the hair, and the knees and the elbows, behind the ears, the sacrum. Those are the most common areas for psoriasis. Typically, you'll have bilateral symmetry, so they would be on both knees or both elbows. And pain and itching, of course, is common, especially the pruritus. So here are some pictures of what the psoriasis and those plaques look like and you can see on the knees where a few of them are kind of look like they are bleeding a little bit and they've broken open. And of course you can see psoriasis on a dark skinned individual as well. Psoriasis management, our goals are to slow that epidermal cell growth and turnover, and of course reduce the inflammatory effects and try to get those plaques to slough off without causing an impairment of the skin. So basically the most important principle is to gently remove those scales. So we'll use bath oils followed by like thicker emollients or like salves and creams that will help to protect those scales and help them to kind of slough off on their own. Medicated shampoos, so especially if they have psoriasis of the head, and they'll have all that dandruff and kind of white, flaking off on their shirts and things, and they don't like, obviously that's a kind of a body image thing for people. They can use medicated shampoos that contain alpha hydroxy acid, and that alpha hydroxy acid is going to help with that. Non-topical steroid or non-steroidal creams, cortisone creams, or even like diphenhydramine or Benadryl type creams for itching. Now, if somebody has severe psoriasis, they can do phototherapy. UVA and UVB light is proven to help with that. And in fact, sun exposure does help. So people that have some sun exposure and have psoriasis, like if they go south for the winter, that will definitely help the psoriasis. And then if they get some sunshine in the summer, if they're up in Minnesota, they don't have as many months where they're actually really having major problems of their psoriasis, or that it is possible anyway. Anti-inflammatory biologic medications, you've probably seen commercials on TV talking about these various ones. So, and these are the ones, the patients that really have a bad psoriasis that none of the other things have worked, and they have tried everything. They've tried the different medicated creams and soaps and oils and things like that. So Humira, Enbrel, Remicade, those would be some of those inflammatory medications, immune modular medications that could be used. Some of those same medications that you can see for like lupus and some other, even like Crohn's disease, some of those other kind of inflammatory autoimmune disorders. And then, of course, don't forget about the body image and how they're feeling about themselves because of those plaques. Herpes zoster or shingles. So now we're moving on to, this is a viral condition. So it's reactivation of the varicella virus or the chickenpox virus. So it's been dormant for years. Commonly most seen in older adults and elderly population, although there have been breakouts like in people like in their mid to late 30s and 40s, especially if they don't have immunity anymore of the varicella virus. So even if they had chickenpox as a child, they need perhaps a booster shot to protect them from getting shingles. So may also come if they have a lower immune system. And certainly shingles is contagious to anyone who has not had the chickenpox or has been vaccinated, or like I said, has an insufficient titer. So I know in healthcare they're having us and requiring us now to have a herpes zoster titer. I know I had mine done a couple years ago, and it was I did have an insufficient titer, even though my mom said I had a really bad case of the chicken pox when I was little. So had to have the the actual two-step boosters shots to protect me from shingles. So manifestations, there's clusters of vesicles that you'll see a picture of here in a second, and they're elevated and usually palpable, and they kind of contain some serous fluid. So the biggest thing with shingles is a lot of pain, a lot of burning type pain. So real kind of nerve related severe pain that people say comes along with that. So the dormant virus resides in the dorsal root ganglia and sensory nerves, and so it's basically like that nerve is infected when that happens, when you get this, and so it hurts a lot. They may also have just general flu-like symptoms, fatigue, malaise, etc. Clinical course varies, but 1 to 3 weeks is possible, with additional healing up to a month. And then post-herpetic neuralgia, hopefully people don't get this, but this could be a complication where you have actually nerve pain that persists greater than 90 days after the outbreak. I know a nurse that I work with that has still some nerve pain like up around her eye, and actually still has kind of some visual changes or maybe even permanent visual damage kind of peripherally out of that one eye because of a severe shingles outbreak. So this is a picture of what the herpes zoster or shingles would look like. You can see the patches. They come in patches of clusters, and you can see the vesicles on a few of those pictures that are kind of more raised and look like they have some fluid in them, and you can see that the skin is very, very inflamed. So it looks much different than other skin conditions, so you're usually able to tell herpes zoster apart from other things, and also the pain that the patient's experiencing really is telling as well. So shingles management is, well, hopefully we want to prevent it from happening in the first place, but if we do have shingles, it's going to be more of a wet dressings or soaks that have aluminum acetate solution in them, oatmeal baths, there's Aveeno type bath products plus lotions, again preventing the spread, so making sure that the virus isn't transmitted to other people who do not have protection of the chickenpox or varicella virus. If they do have outbreak of vesicles and it's within that 24 to 48 time period, then antiviral medications could be helpful, such as acyclovir or famciclovir. Tylenol, Motrin, IV narcotics. I've taken care of patients in the hospital with severe shingles that needed to be hospitalized for IV pain management. Gabapentin, Neurontin, or pregabalin or Lyrica. Those are a couple medications that you might be familiar with for treatment of nerve pain. And so if people have more of that post neuralgic pain, they might be prescribed this type of a medication. Of course, rest and avoid complications such as a secondary infection. Next up is tinea corporis or ringworm. So this is a fungal infection. So fungal infection of the face, trunk, extremities, it can be anywhere. There's ringworm of the body, there's ringworm of the feet. The biggest thing on this type of fungal infection is to know that it is very contagious, spread by direct contact, and is very pruritic. So classic looks more like ring-like plaques that have sharp margins. And so you can really kind of tell. A lot of the time the direct contact is spread by pets or other objects that have been in contact with the animal. So it is viral, and again, many times can come off of pets. So here's a picture of tinea corporis or ringworm of the face, and you can see those couple patches, kind of ring-like patches of dry areas. So this is where it's important to know what it is, what type of agent it is, like if it's viral or fungal. Because ringworm is fungal, then we would know that it's going to be antifungal type medications and creams that would be ordered versus, let's say, herpes was viral, so it was antiviral. So that's where learning the categories helps you to learn the treatment that is going to be expected. So they're not necessarily difficult, all of these conditions, but there are a lot of them. So you just need to study them and make sure that you understand, you know, which is which, so you're not getting them mixed up. Ringworm is, again, avoid contact with the suspected lesions. They're going to use antifungal creams or oral antifungal. It's going to be a major cleaning of all of the environment. We need to get all of the infected fungal scales out. Pets need to be treated or checked out to see if they are also infected. Otherwise, there just is a continuous reinfection of the fungus. So use a clean towel and washcloth each time. So hygiene is very important, but making sure that you're not reusing. And also making sure you're drying those skin folds, because we know that fungus love heat and love the moisture. So you've probably all heard of athlete's foot, and so tinea pedis is athlete's foot. And again, the most common, it's a fungal infection again. It's just that the most common reason is communal showers, pools, excessive sweating, or occlusive footwear where we had excessive sweating and all of that moisture, and then the fungus like to grow there. So most of the time it's on the plantar, the bottom surface of the feet, excuse me, and the toe web. So I just had a patient that had a severe athlete's foot or fungal infection all on the bottom of his feet and toe webs, and just kind of on that bottom area of the foot. So and he was in a facility where they were sharing, you know, one shower, and obviously wasn't probably very clean. So interdigital scaling, crusting, itching, and can have little raised areas as well, and they can be painful. So very important for the management is basically just getting that area to be very clean and dry. Letting it have some exposure to air can be very helpful as well. Again, making sure you're drying really well in between your toes, making sure that we're wearing open sandals or light cotton socks, making sure that we're not, that you're wearing footwear into communal showers and pools and things like that. I know it may seem kind of funny, but making sure that people understand, like, if you have athlete's foot, I need to put my socks on before I put my underwear on. Otherwise, I could be, bringing all that fungal infection up to the perineal area if I get it on my underwear. So those are the details of the teaching that we want to make sure that we talk to our patients about. And then, of course, making sure they know how to use the antifungal creams and powders. So impetigo is next. This is a bacterial infection, and it is most commonly kind of right around the nose area or the mouth, so you can kind of see it. It sometimes can be mistaken for a cold sore, but it is not. It's different than that, because the cold sore is viral and this is bacterial. Common among children and people in poor hygienic conditions, but again, I have a girlfriend that just tends to get impetigo, and she has very clean conditions and all of that, so it's not necessarily just in that area. Very, very contagious. So again, you'll see kind of those little yellow type honey crusties on top of that lesion there in the picture, and those vesicles rupture and then cover with that adherent honey crust. Again, our biggest thing in treatment is going to be to make sure that that we're not sharing towels, and that yellow crust, I mean, that needs to be gently moistened off before we put our ointments on. Otherwise, we're not getting to the base of the problem. So impetigo management, they will probably be on either systemic and or topical antibiotics. So if they're on oral antibiotics, you know all of that, what you would teach about on that from other units. Topical antibiotics, again, the main thing is they need to soak that lesion with some, warm soap and water and just kind of let it loosen so that they can get that crust off without hopefully having it open up and bleed a whole bunch, and then put the topical cream on that. It does no good to put the antibacterial cream on over the top of that yellow honey crusted stuff because that's the infected area. So we got to remove that infected area gently and then put the topical cream on. Good hand washing, not sharing towels, anything like that, makeup, all of those products and stuff, if they're potentially contaminated, need to be discarded. So scabies is next, and scabies is parasitic. It's very contagious. It's a parasitic mite infestation. So again, it's basically transmitted by close and prolonged contact. It's usually poor hygienic or crowded conditions. And again, this is another one that is many times carried by pets, just like ringworm. So again, this looks different than other things. You'll see more of a visible white ridge, and that's formed because the mite have burrowed in underneath the skin. There will be severe itching with it. All family members need to be treated. If one person at the home has scabies, everybody else has to be treated. All of the household belongings, laundry, couches, chairs, I mean, just everything absolutely has to be basically decontaminated to make sure that we are getting rid of all of the parasitic mite. So it can be a real pain to get everybody treated. There's scabicides, Acticin, Quell, Scabine. You'll see some of those, and again, you can buy these over the counter. These are medications that will be used for the treatment. This is a picture of the scabies. They would confirm diagnosis with a skin scraping. Cellulitis is another bacterial infection, and this is a common condition that you'll take care of patients in the hospital and clinics and things with cellulitis, home care settings, nursing home settings. So it's something that you'll come into contact with and should be knowledgeable about. The bacterial infection basically infects the dermal and subcutaneous tissues. There has been some break or loss of integrity of the skin that allows some microorganisms to get in. Sometimes people come with cellulitis and they said that there was maybe like a pinpoint area that they noticed, and then all of a sudden they got a full-blown really bad cellulitis. We see it often of the extremities and the lower extremities, but I've seen cellulitis of the face, the hands, so of course it can be anywhere. There's a lot of erythema or redness. There's localized edema of that area or that extremity. It's very warm usually, and it's very, very tender to touch. So people with severe cellulitis, even when you go to lift up the sheet to start doing your assessment, look at them, they are flinching. They're guarding that area. They don't want you to touch it. They said it's very, very tender. So make sure you're very mindful of that when you're doing your assessments, and that you're letting them know what you're going to do, and that you're being ever so gentle with your touching. If you're touching to assess, for warmth and things like that. They typically, as they get the cellulitis that progresses, they'll be running a fever and they'll be very clinically sick as far as that infection goes. And obviously we want to prevent them from getting a secondary, like a sepsis complication. So we want to keep the cellulitis localized, obviously, and get it treated there before it goes and spreads other places and into the blood. So fever, chills, malaise, we would expect elevated white count, and that elevated SED rate, just meaning that there is an inflammatory process going on. So depending on the severity of the cellulitis will depend on what they have ordered for treatment, whether they have to be hospitalized and on IV antibiotics, or whether or not they can take oral antibiotics at home. As far as bed rest and heat, there's just kind of there's contradictory information, I guess. Bed rest is debatable as far as the idea was limiting muscle contractions, where then that force of contraction could cause microorganisms to go other places and to mobilize into the bloodstream. I don't think you're going to see people really on strict bed rest anymore with cellulitis, because we also do want to keep them moving, and there's other complications that they can get from immobility that are, worse or just as bad. As far as heat, vasodilation, I mean, if we put heat on, that will vasodilate and increase blood flow to the area. So sometimes you'll see, like, they'll order an Aqua-K or a continuous heat pack that we can have on for those patients. Charting, taking a picture, of course, is very important. Charting can be kind of tricky because, redness, swelling, warmth, but I mean, like, how red and how swollen, and how do you measure exactly the whole size and all of that. So do your best to get measurements just like you would a wound, and to try to be very objective of that cellulitis area. And we'll take a black Sharpie and we'll mark the area of cellulitis, and that can be very helpful too. So then we'll know if that redness and swelling is improving or if it's getting worse based on where it is with the markings. I added this in here just a way to reiterate preventing the spread of MRSA, and not that all cellulitis, have MRSA, but there might be somebody with cellulitis that also has a MRSA infection of that area of cellulitis. So just kind of wanted to add this in and make sure that people understand about the antibiotic resistant type things, and that the patient would be in contact precautions, and that we would obviously be washing our hands and making sure that we're doing due diligence to make sure that we're not spreading anything, only using one washcloth and not going between body part areas of the part that's infected, etc. And also, as far as patient assignments, that you wouldn't assign a patient that had cellulitis and positive MRSA of the right lower extremity to also a nurse that has like a fresh hip or knee or surgical patient. So the last of the skin conditions before we start burn injury is skin cancer. When we look at the incidence of cancer, we have breast and prostate as number 1, the lung and bronchus is number 2, colorectal is 3, and then skin cancer comes in number 4 for males and number 5 for females. So it basically is right up there behind breast, prostate, lung, and colorectal. So there is a high incidence, and that we need to be making sure that we are talking with our patients about skin protection and hats and sunscreen, etc. Having skin checks if they are high risk candidates or have a family history of skin cancer, and doing some of that preventative health teaching that we've been talking about all along. So 1 in 8 fair-skinned individuals, so increased risk because they have decreased melanin, and remember, melanin was helping to give UV protection. So that also goes along with patients that can burn easy. Obviously, if I'm fair-skinned and I have decreased melanin, I'm going to probably burn quicker and easier if I'm in the sun without sunscreen on, or even if I'm in the sun with sunscreen on. So you'll kind of see some of those the rest of the risk factors listed there: chronic sun exposure, exposure to chemical pollutants. I mean, it's not just the sun, it's wind, it's chemicals, it's whatever's in the air. Genetic predisposition, there is a significant family history. If you do have family history of skin cancer, there's a high prevalence of your immediate independents also having skin cancer. Sun damaged skin, of course, there's a higher incident in the elderly population because that sun exposure is cumulative, so they over the years are going to have obviously more years of sun exposure. And then smoking or smokeless tobacco, again, this basal cell of the lip especially common with that. It is a very successfully treated cancer. Death rates are low, especially if you're catching it right away. And again, if we can do teaching on preventative, we can work to improve those incidence rates even more. So there are various types of skin cancer, basal cell and squamous cell carcinoma. Basal cell is the most common type of skin cancer. It's the basal layer. It's the lowest part of the epidermis that is affected. So it's more superficial than going all the way into the dermal layer, etc. Definitely with the basal cell or squamous cell, it's more common to be appearing on sun-exposed area of the body. And as we talked about, the incidence is proportionate to age and the total amount of sun exposure as far as the probability of having, like, say, a basal cell carcinoma. So they can come as different things, but typically the basal cell is not, it's more of a red, pearly, kind of waxy type area. It doesn't even need to be raised. It could just be kind of more of like a red circle. It's not a mole. We'll see them when we're looking at the moles. That's more with the skin cancer called melanoma. So this is just more of a red, pink discoloration. So it doesn't always look like cancer, I guess is what I'm saying. Goals of treatment, of course, is to excise the tumor and have a clear margin of what they took out. And of course, our ultimate goal is the prevention of. So avoiding sun exposure between 11 and 3, using sunscreens, wearing a hat, wearing protective clothing with the sun protection in the clothing. Sunglasses, super important there. Being mindful of looking at yourself as far as moles and other areas of your skin. If you're noticing any spots or scars or lesions that seem different, that you would get those checked out right away. Also, areas that have a lot of itchiness to them, they could possibly be an area of carcinoma. So here's clearly a more late, squamous cell carcinoma of the face that, hopefully we can identify earlier than this. So malignant melanoma is the most lethal and most serious form of skin cancer, and definitely need a thorough assessment done if you're at risk for this, or if you have had a melanoma before. You'll be on, every probably 3 months initially, and then every 6-month checks, full body skin checks by a professional, by a dermatologist or an advanced practice nurse working in dermatology. And ultimately they'll have to, do an excision to do the diagnosis of melanoma. So as far as melanoma goes, this is definitely more looking at the moles and looking at changes in moles. So we'll have a slide coming up with that. We do know that higher in women, and definitely still incidence does go up with age. It occurs anywhere in the body, even non-sun exposed areas, which is quite different than, like, say, the basal cell carcinoma. This is a very much higher incidence of use of tanning beds. So obviously that would be a totally preventable, not using tanning beds where you would have that increased exposure. Same prevention teaching, same screening. The only other thing would be to make sure that we're letting patients know that if they do have first-degree relatives, that they need to have those others. So like if you have a parent that had malignant melanoma, then you would also have it, as well as then your children. And we just need to make sure the family is aware that this is a very, very high genetic predisposition. And so everybody needs to be checked for this more diligently. I have this slide on here hoping that everybody can spread the word and educate. These are the sunscreen ingredients that are effective protection against skin cancer. So not all sunscreens contain what is needed to have protection. So we can't just read the label and just say, oh yeah, SPF of whatever, and just assume that it's good. So making sure that you're looking, it doesn't have to have all of them, but it has to have at least one, and obviously if it has more than one, then that's awesome. And I was also just going to make sure that everybody knows what solar protection factor means. So SPF of let's say an SPF of 4 versus an SPF of 50. So it's not really the strength of that sunscreen, or like, oh, an SPF of 50 is protecting you way better than an SPF of 4. It's the amount of time that you're getting for that SPF protection is what it's actually telling you. So SPF tells you the length of time that you would be protected. So for example, if you would normally get red or start getting pink, or a little bit of a burn in 10 minutes, and you had an SPF of 4 on, you would have 40 minutes of protection, of solar protection time, 40 minutes. So obviously if you're wearing an SPF of 15 or an SPF of 30 versus like 4, it's just giving you more time, so that if you didn't reapply as quickly as you were supposed to, you don't have gaps in the protection. So that's and essentially why like a higher SPF would be better. Not that it's better because it's protecting you better. So I just want to make sure everybody was clear on that. You know, they recommend a higher SPF in infants and children. Well, that's because they don't want parents to forget to reapply. You know, it just makes sense. So, but if you have, I have had malignant melanoma, and I am, oh gosh, that was in 2008. So I guess, 11 years without a reoccurring cancer, which is great. But I use, my doctor said you can use 15, you can use 30, it doesn't matter as long as you're always wearing sunscreen and you're always reapplying. So for me, for my kids, it just everybody knows that we're wearing sunscreen, we're reapplying, we're wearing hats, we're going to take shade when we can and go from there. So it doesn't mean that we have to be hermits and, not ever be in the sunshine. We know that sunshine is good, it's healthy for lots of things, psychosocial, psychological, etc. But you just kind of have to be smart about it, I guess, more than anything. I should just say on a side note, as far as my melanoma, it was in a non-sun exposed area, huge genetic predisposition, did not use tanning beds, maybe a little tiny bit like for high school prom, I remember, and a few times in college, but nothing major, like not like what I see a lot of younger people doing now, or it's getting better actually. So again, malignant melanoma is more of that genetic predisposition. I grew up on a farm. We did not have sunscreen. We did not have any sun protection. I mean, I was outside all day, every day playing on the tractors, baling hay, riding my bike, and so when you talk about that, it's all of those years. So like hopefully this is going to be getting better like for our children, because at a young age our children were already at least wearing sunscreen, even though they were outside a lot because kids are busy and they're in sports and baseball and t-ball and all that, which is great, but they're actually at least having some sun protection. So that cumulative effect and the genetic predisposition are the two things that the doctor said for me were really, really huge, because I didn't start wearing sunscreen like for tanning, like fishing or out fishing or things like that till probably I was like in my early 20s. Just kind of was non-existent back then. So here's a preventative health teaching: slip, slop, slap, and wrap. So making sure that you're slipping on a shirt and putting some sunscreen on, a hat, and then the protective eyewear. So here again for our own family members, for being healthcare professionals, I mean, we're doing head-to-toe assessments. If we see a mole that looks asymmetrical, you can see the shape is asymmetrical. There's definitely several color variations in this mole on this slide right now. Those are a couple really big things. So asymmetrical, the border is irregular. There are several color variations. Diameter, they say if it's larger than the pencil eraser size, that and or if that changes very quickly. So if the diameter if it's fast growing, that could also be, even if it was smaller than a pencil eraser, but it went from like pinpoint to bigger quickly, that would be notable. And then again, the elevation and enlargement. So any of these things would be potentially reportable things. And I can just speak, and I'm okay sharing, but mine was like in my groin area, and I just noticed, it's not like you're like staring at yourself, down there, but I just noticed it was just a little small little mole that I hadn't noticed before, and then like a couple months later it was already like way bigger. It was at least like pencil eraser size probably. And I've had moles removed even since I was like 16, suspicious moles, and none of them ever had been cancerous, but I had like probably 10 by that point that had been removed and sent in and nothing. So at that point you're kind of like, whatever. You kind of get a little like, oh, it's nothing. It hasn't been anything all this time. How would it be now? So I guess for me, I was in for just a routine. Well, actually, no, I was in for being treated for, I got the happy to have the adult onset acne after all my kids, and I never had acne at all in my younger years. I was being treated for that, and I just happened to show the dermatologist that, and they biopsied, and sure enough, it was a pretty progressive melanoma. So it's weird how things go, and we just have to be, I guess, trusting of, hey, it looks different. I mean, it didn't hurt, it didn't itch, it didn't anything, but to have it checked out and have it biopsied. And again, same thing for your loved ones, family members, friends, and as nurses, if we can pass any of that along to be evaluated, if we see something in somebody or we see they have a family history of skin cancer, that we don't be afraid to talk to them about that as well, because very very good success rates if caught early. I mean, I ended up having to have surgery more than just, an actual excision at the clinic, unfortunately, because my excision didn't come out with clear margins. So I had to have sentinel node, biopsy, and surgical removal of like 60 some lymph nodes, etc. So, and even then, I guess it was, I reported it as soon as I thought was, I don't know, it wasn't a long, long time. It was a matter of a couple months. So really important to just kind of act on things, right away. And here's a nice Creative Memories notebook to explain some priorities for catching malignant melanoma, identifying it early. And then lastly, what types of nursing diagnoses would be priorities for anybody with any skin condition? And I think some of them are obvious. Impaired skin integrity is obvious. Acute pain or impaired comfort as far as the itching would be obvious. They could have disturbed sleep pattern because of the pruritus probably. And then certainly body image. There's a lot of knowledge and teaching and prevention and all of that. So hopefully you can see that all 5 of these diagnoses pertain. They're not necessarily in the priority order that I have them listed, but we could put them in order if you needed to. So the answer here is 3, psoriasis. The answer here is 3, wear plastic shoes or sandals. Answer is number 4, the epidermis is responsible for barrier protection, phagocytic action, the melanin, and then a huge part is the maintenance of hydration status. Correct answer is number 1. They're going to instruct the adolescent to start by washing the face with mild soap and water, or they might be able to, again, get some of the over-the-counter. Tretinoin is over-the-counter, benzoyl peroxide wash, so they'll start there first. Number 4, the tretinoin, it says in the morning and exposed to face. Tretinoin has a significant sun exposure. You're going to burn very easy if you're using tretinoin. Also, if you're using Accutane, so that would be teaching to have extra careful sun protection for tretinoin or Accutane.